introduction. Just to review my background briefly, I am a child abuse pediatrician housed at the University of New Mexico Children's Hospital. Child abuse pediatrics is actually a fairly new recognized subspecialty in the pediatric field that requires fellowship training and a board certification. And it's still a relatively small field. There are only 2 of us here in New Mexico who provide this level of clinical service. And for that reason, outreach education has become very important to us, so we can share the experience that we have with all sorts of other healthcare providers in our region, because the recognition and treatment of child abuse is incredibly important. And many of the referral sources that I have are actually individuals and the types of physicians that we have in the audience today. And so I'm so glad that you guys were able to join us, and I hope that this is helpful for you. Some of the introductory exploratory questions that I've surmised for this talk are displayed right now. The first is for reflection. Have you ever had difficulty recognizing whether a child that you're working with has injuries that might be due to physical abuse? And this is a huge topic of concern for all professionals tasked with the care of children, because we certainly want to recognize child abuse if we're seeing it, but there's also a recognition of the fact that going through an assessment for child abuse is traumatic to children and families, and we certainly all want to get it right and know to be concerned when we should and not be concerned when we shouldn't. Question number 2 is, do you feel confident in your ability to recognize and report when you have a reasonable concern for child abuse? And I focus this question to New Mexico. I know we have some attendees potentially from Arizona, and I'll try to address referral and reporting in that state as well. And the third question that I hope you can answer after today's talk is, do I know when I need to consider referral to a child abuse pediatrician, so a medical specialist, to help me evaluate a child who I'm concerned may be abused? The primary focus of my talk here today is the manifestation of child abuse through bruising. And the reason that I focused on that topic is actually twofold. Number one, very obviously, because bruising is the most common injury that we identify in cases of child abuse. The other reason I felt that bruising was an important topic to address with this audience is that bruising is a very visual injury that is commonly recognized by non-medical care providers even, or by medical care providers who aren't doctors. In fact, most of the patients that are referred to me come to me because some concerned family member or concerned professional in the child's life, such as a teacher, a school nurse, a home visiting specialist, a therapist, recognizes an injury that's concerning to them. So I think an overview of this topic is essential for the audience we have today. The other reason it's important to talk about bruising is because we recognize that bruising is very common in children. In fact, it's common in all of us, which adds a level of complexity to the evaluation of bruising in the context of child abuse. One thing we look at when children are referred to us for bruising evaluations is, where do they have bruises? And certainly we all recognize that when we see children who have bruises on their extremities, so their arms and legs, particularly over the bony prominences such as the knees or the elbows, is not usually concerning. Other areas of the body that we commonly see bruises in active children are the chin, the forehead, even sometimes the cheekbones. Any area of the body where there's skin overlying a bony prominence is an area that can bruise with more minor trauma, and areas that tend to be the first impact sites in minor trauma. There are, however, some areas of the body where bruising is less common and should at least cause someone to question whether this could be an inflicted injury. And the categories that we focus on are bruises in a central location, so meaning bruises on the abdomen or the chest, or a bruise on the back that's not over the spine, and then of course bruising on the buttocks or genital region. These are very unusual accidental bruise locations. Anytime you encounter bruising in a non-ambulatory infant, and this is a point I think is really important to as a take-home for our home visiting specialists who spend lots of time with families who have very young infants. Infants who are pre-mobile really should not get bruises. Our rule of thumb is if it doesn't cruise, it shouldn't bruise. And in my experience, infants, particularly before 6 months or before mobility, who have bruises are either being abused or have some sort of bleeding disorder that needs to be diagnosed. So it's very important that those kids are not ignored, even if you're seeing what looks like minor bruising. Third, anytime you see a bruise in the pattern of an object, and there are some specific objects we'll talk about later, and that should heighten concern for abuse, because it's likely that some sort of implement could have been used to inflict an injury to the child's skin. What we're going to do next is primarily focus on a visual presentation of child maltreatment in the context of bruising. And I know these slides are graphic, and I apologize for that, but the unfortunate reality is that this is the nature of the work that we do, so we need to be able to look at the presentations. This first slide here depicts a young infant who was, I think, about 6 months of age when I saw him, who was admitted to our hospital after what was described as a short fall in his home. And when he came into the hospital, what the emergency medicine doctors astutely recognized was that he had a number of bruises on his face. And if you look up at his forehead, you can see at least 3 areas of bruising on your right, his left. He has bruising around both of his eyes, more pronounced on his right eye. He's got some abrasions on his lips and around his nose, and he's got a large bruise on his left cheek, and even a bruise underneath the left chin. This is a child who couldn't walk, couldn't crawl, couldn't stand, and allegedly had taken a fall down 1 step. But what we see in his presentation is that he has multiple areas of impact. When we see this, what we do is a thorough medical history and screening laboratory tests to look for any bleeding disorder. And in most cases, the unfortunate reality is what we find is otherwise healthy children who have multiple unexplained impacts. And this is a very classic manifestation of bruising child abuse in a young infant. One other interesting point to know about this patient is one of the reasons he required ongoing hospitalization is that he actually had intraoral trauma, and the swelling to his buccal portion, so the fleshy portion of his cheeks when he came in, was so great that he couldn't eat or drink. It's difficult to appreciate here, not seeing a before or after photo, but his cheeks are very, very swollen. So he stayed in the hospital with us for a couple days until he was able to hydrate himself again. The next bruise we have is the bruise to what's called the pinna, or the exterior portion of an ear in an older child. And what you can see here is a deep purple band of bruising on the top of that ear. Another highlight of this talk is if you see bruising on an ear, you should automatically be concerned for inflicted injury. And the reason for that is that the ears are just structures that aren't commonly significantly impacted in accidental injuries, and they're not particularly vascular. The skin overlying the cartilage of the ear has small blood vessels, but the cartilage itself is not vascular. And the typical mechanism we see in deep bruising like this is that someone has pinched and or pulled the ear or boxed the ear. This type of injury is more common in older children who can typically tell you what has happened to them. And this child in particular was able to tell us when she presented that her father had pinched her ear and physically pulled her by the ear, leaving this type of bruising. And one additional note on ear bruising is if you see bruising on the front of the pinna, always fold it down and look to the back, because you'll typically see it on both sides. The next slide is a visual of what abusive spanking injury looks like. And I always include this slide because spanking is a very controversial form of punishment in our local culture and society-wide. And many people ask me, how do you know, Dr. Strickler, if a child who's been spanked has been abused? And the answer that I give them is a provision of a visual like this. When we look at the New Mexico legal codes, nowhere does it say that it's illegal for parents to physically punish their children or spank them. But what our legal codes do tell us is that if in the act of physical punishment you cause tissue injury or bruising, you have crossed the line into an abusive situation. And the unfortunate reality is that most patients who are referred to me for bruising evals of the buttocks come in looking like this. And this is a child who has such deep tissue injury that it encompasses all of the buttocks with a bit of sparing on your right side near the gluteal cleft, which typically happens when the child clenches due to pain or fear. But this is an example of a child who's had multiple impacts and suffered deep tissue injury. To me, it's not subtle at all that this has crossed the line from acceptable discipline into abuse, and which is why I do consider these abusive injuries, and again, it aligns with what our legal codes in our state dictate. We also often will see pattern bruises on children who come in for evaluation. And what you're seeing here is the back of an older child who has a large loop-shaped bruise. This was a child who was actually struck by a belt that was folded and hit perpendicular to the spine. But this is also a pattern we can commonly see in other flexible implements, such as cords or wires. And again, it's more common to see this type of injury in older children who can give detailed history about what has happened to them, but it's not exclusive, and I certainly have seen some infants with these types of patterned injuries. When we're dealing with children who are being spanked or struck as a manifestation of child abuse, the common locations that we see are injury to the back, injury to the buttocks, or injury to the top or posterior legs, just because that's classically where people spank. So location can give you a hint as to what's going on, but the pattern is usually the telltale sign. One other teaching point I always like to make when I look at pattern injuries that are large is you want to look at whether the injury follows the contour of the body, meaning do you see a bruise that wraps around from the back to the front, or does the bruise stop in one plane? And again, what that tells you, if you don't have a clear implement or weapon, is if a bruise wraps around the body, that's an indication that whatever struck the child was somewhat flexible or malleable. Whereas if you see injury only in one plane, that tells you that a very rigid instrument is what was used to strike the child, and that can be useful to law enforcement who may be looking in the course of a home investigation for what they would consider a weapon. So this is an example of a looped injury that doesn't really cross contours, but would have potential to do so based on the fact that it was a belt. The next slide we have is also a visual of inflicted injury from a belt spanking. So again, you see this is an older child who has injury to the back. And what you can see here is a nice semicircular outline of a belt buckle and a belt clasp. So this is a child who's been struck with a different part of the belt, but this is also a classic pattern that we can sometimes see. And when you see a pattern this specific, it's often possible to even identify, a specific implement that has been used. This next slide it depicts a very classic pattern bruise of a child who's been slapped. We often see this type of injury in toddler age or early young children who have angered a caretaker and as a result been struck. And again, like spanking, this is a somewhat controversial type of injury. However, again, based on our legal codes, when we see children suffer deep tissue injury as a result of that impact, that crosses a line into the realm of abusive injury. What we most commonly see in children who've been slapped is a series of 3 or 4 linear parallel petechial bruises. So you're not always fortunate enough to see a classic outline of fingers like we see here. This is just the best depiction I've ever had of a slap mark, so I wanted to include it. But what's more classic is just, again, linear parallel bruises, either on the cheeks or the temporal region of the face. And again, it's more often that this is seen in older children who can give a history. And in my experience, if a history is not provided by the child, when I point out what the pattern tells me to a caretaker, they often then acknowledge what was done because they realize that it's such a telling pattern of injury. Another common type of inflicted injury that we'll see in children is someone has grasped them or grabbed them to either immobilize them or punish them in some way and left marks on their body. Now this type of injury assessment can certainly be more difficult because the patterns are not quite so pristine as some of the others that we have seen. But this is a child who did have a much more classic pattern of a grasp mark on her upper arm. So again, we look at the location of the body. The arms are a classic place that a caretaker will grab a child to hold them or immobilize them. And in many cases, all you'll see is a series of circular bruises that are not in any clear pattern. But in this child, what we see is a series of really oblong bruises that are parallel to one another with circular or bulbous endpoints. So this really is a case where the outline of someone's fingers were truly left on this child's body. She did not disclose the specific history at the medical examination, but during protective services interview, she was able to tell them that a caretaker had grabbed her and left these marks. Other places that we typically see these types of grasp marks are on the forearms, particularly in younger children, and sometimes even on the anterior or posterior thighs. And to follow up that statement, this is a classic appearance of a grasp mark injury on a very young infant. This was about a 2-month-old baby who came to our emergency department with a report of a rash that his mother didn't know how he had gotten. And the ER doctors astutely recognized that what he actually had was bruising, and there was this very interesting pattern that they couldn't quite make heads or tails of, so they called me to come see the baby. And this is probably the 4th time now that I had seen a young infant with this type of pattern bruising on the forearm. And when you look at the bruising, you can see again kind of parallel bruises with an interesting T-shaped pattern. And what those are is bruises that line up with the palms of the hand as they extend out to the fingers. So when someone envelops a newborn's arm with an adult-sized hand, you leave marks from the palm itself and again the interspace between the digits. Very classic. And again, this is a child who went through a full hematologic evaluation and wasn't found to have any predisposition to bleeding. So a classic diagnosis of abuse. Strangulation is another unfortunate mechanism of injury that can lead to bruising, which can really lead us to an understanding of what has happened to the child. Fortunately, strangulation is not a common manifestation of abuse, but it is unfortunately very effective in terms of causing harm and can cause great bodily harm to children, so we certainly want to be able to identify it when it's happening. What you're seeing in this little girl is a very diffuse pattern of what we call petechial bruising, and petechial bruising occurs when small vessels at the surface of the skin are ruptured due to pressure. And this child was able to disclose that her mother had become upset with her and picked her up by her neck and squeezed her, and what was left, although not any clear patterned hand mark injury, were just again diffuse petechiae that extended down to the top of her chest. And what's also not displayed real well in this picture, she actually had sparse petechiae all over her face. The reason we see that in strangulation type of injuries is that the venous blood flow from the head back to the central portion of the body is obstructed when the neck is grasped and compressed. And due to that increased pressure, you'll often see petechial bruising all over the face and head. A common misdiagnosis in this type of presentation is that a child is taken to a doctor, shows up at school, and has what someone thinks is a petechial rash, which we can sometimes see associated with viral infections. My word of caution to providers out there is if you're seeing a child who has what you think is a rash, but it's isolated only to the face, neck, or top of the chest, that doesn't fit with any infectious presentation unless it quickly spreads down the rest of the body. So if you're seeing isolated petechia, don't assume that this is associated just with some mild or even significant infection. And particularly you want to take into account what is the other health status of the child. Do they appear to have any signs of infection otherwise? I can't tell you how many kids I've had referred to me with missed petechial bruising due to suffocation or strangulation because somebody thought that they just had a little bug. One thing that we're commonly asked as child abuse evaluators when children present to us with bruising that's felt to be inflicted is, doctor, when did the bruising happen? And that's certainly important from an investigation standpoint to try and identify who may have caused an injury if that hasn't been disclosed in a history. As much as I wish we had the capability to look at bruises on children and specifically date them, the validated science is just not there. And it's not because as care providers we don't have the capability or we're dumb. The truth of the matter is in different scenarios bruises will evolve differently, and how a bruise evolves and resolves will vary with the location of the body that it's on, the depth and severity of the bruise, the tone of the skin of the person who has the bruise, and how vascular the area of the body is that has been bruised, and even the age of the patient. There's just way too many factors that go into affecting how bruises change over time for us to be able to pinpoint very specific time frames of bruising. I think the only well-validated assessment of bruising dating out there is the fact that if you see a yellow coloration to a bruise, you can be fairly certain that bruise occurred more than 24 hours or 24 or more hours before it's been recognized. But beyond that, we just don't have a lot of specificity. And interestingly, people have actually studied physicians' capability of dating bruises in children, and I have these references listed here if anyone wishes to read further. But what investigators looked at is primarily ER doctors and family doctors, their capability of timing bruises from one physician to another with a series of pictures and children. And what both studies found was about a 50% inter-observer reliability, meaning the doctors agreed with each other about half the time in terms of the dating of these bruises. So it just demonstrated the fact that we're not good at doing it. So now that we've gone through a visual depiction of what bruising can look like in cases of maltreatment, we'll move on to reporting concerns for abuse or neglect. And again, I think this is important because I think most of the people attending today work with children in a capacity that you're in a position to have to or need to look at their bodies, particularly if you're in nursing or doing home visitation. One pearl I always give to people is, even if your role is not to be dealing with a child in the specific medical presentation, always pay attention to what they look like. And certainly if they're old enough to call attention to any injury they have, take a close look at their body, ask them what's happened to them, and it will help you know if this is something that rises to the level that you need to have help in assessing from other doctors or from protective services. And you should know that in New Mexico, all adults are considered mandated reporters for suspected child abuse or neglect. So basically, no one is left off the hook in our state. We really place responsibility on everyone, and the mentality there is that everyone should be charged with the welfare of our children. One thing to know that our legal codes do specifically name certain professionals whose work is focused on children as having increased responsibility in reporting, and that includes physicians, nurses, and social workers specifically. Other inclusions are clergy and teachers, but I think basically everybody attending here today would fall under that category of someone with even increased responsibility under our legal codes. So if you get to a point where you've seen a child and they have an injury that concerns you, the next thing to know is who do you contact? And your number one call should always be in New Mexico, CYFD, which is Children, Youth, and Family Services, and that's our protective services organization in our state. You can access their website at cyfd.org, and reporting is actually quite simple. You can dial #SAFE from a cell phone or dial the 1-800 number listed here from anywhere in our state. When you do that, they're a 24/7 access line. You will get to an operator who will review a lot of demographic information with you. And one thing I always tell people is when you're making a report, make sure you have enough information on hand about the child and the family to give to protective services so they can locate them. And it will be very important for you to have a name of the child and name of the parents if possible, and most importantly, contact information for the family, including a phone number and an address. The most common reason that reports end up getting screened out when people who are well-intentioned call them in is that CYFD actually can't find the child or the parent. So certainly if you're in a medical setting or in a setting where you can have access to any demographic information about the child, have that with you when you make the call so you're well prepared to give them the information they need. Because we live in a very large and diverse state here in New Mexico and in Arizona as well, one thing to know is that there are different jurisdictions for the evaluation and investigation of child maltreatment on tribal land versus non-tribal land. Each individual tribe has its own tribal social services agency, and they do have jurisdiction in the investigation of child maltreatment. One thing that can be difficult is some of these agencies are understaffed and don't have the same level of access that CYFD has, and it can be hard to figure out who it is you should be calling. And if you're fortunate enough to work in a healthcare setting where you have a social worker who's well versed in our system, they can typically guide you through this. If you're not fortunate enough to be in that situation or have connections to your local tribes, what I always recommend to people is that you report to CYFD, because what they will do is a courtesy coverage, opening investigation, and then determine who has jurisdiction and make sure that the case gets transferred. So when in doubt, report to CYFD is the bottom line there, but do recognize that CYFD will not have ultimate jurisdiction in many tribal cases. Over the years, when I recognized the need to address communication with our families in the realm of reporting child maltreatment, And that's been important for me to recognize, because as a child abuse pediatrician, I'm very comfortable with talking to families about child maltreatment and about the need to report. But I recognize that this is not something that many of my colleagues do on a daily basis, and it's very stressful for professionals and for families to go through. So I always like to give a few tips to people about how do you pursue this type of reporting in terms of communication with your families, so as not to make it more stressful for yourself, for them, or even unnecessarily escalate a situation. And I think that most of these tips are actually fairly straightforward, but it's always good to use objectivity and common sense to think about and apply them. Rule number one is talk to your family. I treat child maltreatment just like any other pediatric disease process, and that means it's one that requires transparency with our families. I feel that it's important to objectively discuss with our families that we have a legal duty to report anytime we have a concern. One thing that can do for providers that's nice for you is really deflect anger. If parents understand that, hey, it's my legal it's a legal requirement that I make this report if I'm concerned, and that gives you a bit of an out. They recognize you're basically doing your job and you're doing what's right for the child. The one caveat I always include here is if you do have a true concern about your own safety or the safety of the child, by disclosing the fact that you're going to make a report, certainly that would be an instance where you don't want to do that. But my experience has been, in most cases, if we're open and direct with our families about our need to do this, they're very understanding. In most cases, when families give me negative feedback about the process as it's evolved up to the point that they see me, it's that they feel that they were blindsided and they feel that people weren't honest with them about their concerns, and all of a sudden they end up in this big mess and haven't understood why. As I mentioned before, you always want to have detailed demographics available when you're making a report. I won't belabor that. When you do call CYFD, they are legally required to ask any referral source if the person wants to remain anonymous. And although that is your right, we always recommend to any professional charged with the care of children that you do identify yourself when you report to CYFD for two simple reasons. Number one, all reporting is anonymous, so CYFD will not disclose your identity to a family. Number two, if you have been transparent and objective with the family, they should already know that you're making a report. And number three, if CYFD needs to contact you for any follow-up information as they progress through their investigation, if you've reported anonymously, they have no way to do that. And it's not uncommon at all that they will want to recontact someone who's made a referral to get additional information. So I always encourage people to try and make yourselves available so they have that resource. The final phase of this talk is addressing the need to know when you should not just refer to CYFD, but also consider referral to a child abuse pediatrician. So knowing when is it that my child needs an increased level of medical care and medical assessment for whatever injury or situation that I'm seeing. And the first and most obvious, I think, is if you're seeing a physical finding and you're not sure it's abuse or not. As we saw on some of our slides, there are some manifestations, particularly in terms of bruising, that are very obvious to people even without any medical training that they're abusive. Sometimes it's just very clear. And that may be a case where outside of a need for documentation, you don't need a doctor to look at the child. But there are many, many more cases where someone has a reasonable concern, but it doesn't have the background or doesn't have the resources to be able to do a thorough assessment and really come to a definitive conclusion about whether the child's been abused. Those are the cases where you really want to access a child abuse pediatrician, or at least a pediatrician who's comfortable in these types of assessments. Anytime you're in the unfortunate instance of caring with an abused patient who requires some other sort of ancillary care that is not available in your practice environment, you want to refer them. And certainly when we're talking about academic and university-based medical centers, many of the children that I end up seeing require care from orthopedic specialists, from neurosurgeons, from eye doctors, types of pediatric specialists that just may not exist in other places. So that can also be an indication to send them into a larger center. One service that we offer here at UNM that really is a manifestation of bruising is bite mark analysis. That's very interesting in that the most common cause of bite marks in children is actually bites inflicted by other children. But the reality is adults can also inflict these types of bite marks, and it's very difficult to sort that out. Was there a question? We actually have a forensic dentist on staff at our child abuse team at UNM who does visual assessments of bite marks for us to help us determine if a children has been bitten or not, and if they've been bitten, if it's a bite mark from a person versus an animal, and most importantly, if it's a human bite mark, is it a bite mark from an adult or a child? He has a level of expertise even beyond mine that I value, and has done some great work for us. So those are always good kids to refer in. And as I mentioned before, anytime you see injuries of any sort in premobile infants, please, please, please be concerned. I have taken care of more than I care to count young infants who come to the university with serious injuries such as broken bones and brain injury. When I review medical records, find that someone had seen maybe 1 or 2 bruises that just got brushed off or explained and never really vetted appropriately. And in these cases, what tends to happen is that if the more minimal findings of abuse aren't recognized, the abuse escalates over time. And certainly none of us want to see children come in with significant neurologic injuries, musculoskeletal injuries, or God forbid even death because we failed to recognize minor manifestations of injury that weren't making sense previously. So for New Mexico, the primary referral resource we can offer through the university is our child abuse response team. We're called CART. And what we are is a multidisciplinary team staffed by 2 child abuse pediatricians, 1 forensic dentist, and then a host of social workers and 1 nurse who is really the glue for our team. We provide both inpatient consultation services, so doctors who are taking care of the kids in the hospital can call to have us see children, and we also have an outpatient clinic that runs most Monday through Fridays. And one of our primary referral sources is CYFD, but also nurses and other doctors and other healthcare providers in the community. We take outpatient consultations basically from any professional who cares for children. Our contact information is up here on this slide. We have multiple contact numbers, and that's basically because we're a pretty small service and we're pulled in many directions frequently, particularly in court, so we don't always have a doctor available to talk on the phone, but my nurse or social worker always carries our traveling pager during business hours, so if you give that line a call, someone will get back to you. Because we only have 1 full-time position between the 2 of our child abuse pediatricians, we're not able to offer 24/7 call coverage right now. That's something I do hope to change in the future as we expand our service. But if you have a child who you would like to be referred to our clinic, we have an after-hours message line that's listed up here now, and the area code is 505, just to be clear. That you can call and leave a message indicating the child's name and the reason for referral, and then just like with CYT, if you give us enough information to track down the child, we will get them scheduled to be seen in our clinic. And that is the culmination of the slides that I have for you today. I'm happy to take any questions if you all have them.
And to start us off, we had a question come in through our software.
Sure.
One of the participants asked, if a student or child informs of being spanked and slapped while at home, but doesn't report to teacher or school official, or even to school nurse right away, what are some signs to look for when signs of redness fade away?
Well, that's a good question and a tough one. I think in that scenario, the history or the disclosure that the child gives is really the most important factor to look at. And some questions that I would suggest starting with is asking the child who has spanked them, how often they get spanked, and again, you have to target these questions to their developmental level. Maybe just saying, do you get spanked a lot? Have you only been spanked once? Older kids will be able to give you more detail. Ask them why they're getting spanked and what they're being spanked with, and that can give you some indicators of what's the pervasiveness and severity of the physical injury. If you have a scenario where a child discloses but doesn't have acute findings at the time, the reality is there probably isn't anything on physical examination that's going to clue you in, which again is why the history is so important. But really, focusing back on those presentations we talked about in the beginning, is are there bruises on the child in unusual locations? If they're comfortable and if you're in a position to do this, take a look at their back, take a look at their butts, take a look at their thighs and see if you're seeing any bruises there. And the other thing that I do when I see kids is I do a full head-to-toe examination, and even if I see bruises that are not concerning to me, I always ask the child how they got them, because it makes them comfortable with talking about any injuries that they have, and it gives you a way to assess their ability to report history. If you have a child who's got bruises on his knees and shins and he can't even tell you how he got those, he may not be able to disclose. Whereas some children will be able to disclose abusive injuries very well, but if they have other normal childhood injuries, they just may not know how that happened because they're so common. But that's a tough question. What I would say in that situation is really you're going to need to rely more on the history than the physical findings if you feel like you're in a scenario where there's really faint markings. Any other questions?
Did we have any other questions for Leslie Strickler? And also, if anyone has joined us who has not said their name and would like to receive CMEs for this session, please say your name.
Laura Romero with St. Joseph Community Health.
Thank you, Laura.
No. Are you listening to me?
Okay.
I'm not hearing
Well,
you.
thank you. Was there a question? I'm sorry? All right, that brings us to a close today. Thank you very much for joining us. Please go to envisionnm.org to our calendar for future sessions and to see what's coming up, as well as information on consulting with our experts here with your patients.
Oh, excuse me.
Yes.
Did you hear Mary Garcia say her name?
I do have
With
Mary
St. Joseph
Garcia
Community
listed.
Health? Oh, good. Yeah, he's got you. Yeah, she just, yeah. Thank you so much.
Thank you. And again, thank you all for joining us, and we will sign off.
Okay, thank you.
Thank
Bye-bye.
you. Very interesting.
You're welcome. Thanks for coming.
Okay, thank you. Have more. Bye-bye.
Thank you. Bye.
Bye.
It's over. It was good, though.
PTSD. Usually,
Yeah.
the response to the lectures I get is either nobody has any questions at all because they're all like depressed or shocked,
Right.
or they ask questions forever. There's no
Gotcha.
in between. It's like, and once it's like kind of a snowball effect. Like once somebody starts, so this was actually pretty good.
Good deal. Good deal.
I hope that was used. It's nice to see kind of the mix of people that attend, because I think for anything in the future, I can even more clearly direct it toward these types of professionals.
Yes, a lot of, especially our pediatric nutrition telehealth program that Kirsten Bennett does, the attendees have changed quite a bit how she presents and what she presents.
Interesting.
Because we get lots of IHS people on that one.
Yeah.
For some reasons.
That's cool. I think what's interesting about child maltreatment is I think a lot of paraprofessionals or people, and a lot of people think it's not something that I need to think about, or it's not something that's important, that I'm going to pick up. And that's why I love these audiences, because the reality is, a lot of these people could be the first ones who could see the findings. So
Right.
that's why I think bruising is such a good topic for this type of audience. So I hope they liked it. But
It sounds like they did. It was a good turnout.
oh, was it? Okay.
Yeah.
No, I have no frame of reference. So.
Gotcha. Yeah, typically we get, a dozen, 15, something like that at our
Oh,
establishment.
wow. Well, that's good.
So this was a very good turnout.
Good. Well, I would be happy to do more, and I kind of like this, the shorter it's easier to prepare shorter talks.
Sure, yeah, exactly.
And
Fun
we
slides.
have a lot, I can look at a lot of, burns. You could do a burn talk. You could do a fracture talk. You could do a head trauma. It's really, the field lends itself nicely to doing really segmented lecture topics. So there's
Segmented
many more.
and visual.
Yeah, we could do.
Okay.
If the feedback is decent. I kind of, with Jane, just said, well, let's do one and see how it goes. And
Yeah, I
we'll
think
go
it
from
went really
there.
well.
Good.
Yeah, and I think people, if this is developed more as a series,
Mm-hmm.
like we're talking about doing, then people will come in with more questions.
Perfect.
The discussion will get a little more robust,
Robust,
as well.
yeah.
So, but a question or two is good too.
Yeah.
So,
All right.
great.
Is there an
Thanks so much.
evaluation? Like, do they do evaluations? Is there any feedback we get
No.
beyond letting some by?
If I do get any, because there's a follow-up email that automatically goes out, and I receive any responses, and any responses that I receive, I'll send them
Okay,
to you
yeah,
for
I
sure.
always like to hear that.
That's about it. We don't do an evaluation, except we do one at the end of the year, the end of the school year. We send out to everyone who's participated, just a survey in general. So this topic may or may not come up in
Sure.
that survey.
Gotcha.
It will, but I don't know how much feedback we'll get
Okay.
for it. So.
Alrighty. Well, thanks for
Are you heading straight out, or are you heading to?
I'm heading straight out.
Because you can go out
If
that
I
door,
can
it's a
find
lot
out.
closer.
Gotcha, thank you. I go to the second floor a lot and I get lost there all the time.
Oh, God, yeah, it's a maze down there. Been there a couple times.
Thanks so much.
Thank you.